So, good afternoon and good evening, ladies and gentlemen. Welcome to yet another edition of our Fungal Frontiers webinar. This is a series of webinars hosted by the AFWG and the ANZMIG. The AFWG is the Asia Fungal Working Group. We are a working group of ISHAM, and the ANZMIG is the Australia-New Zealand Mycosis Interest Group, which is an interest group of the Australasian Society of ID. We have a very interesting case today. I'm Ban Hock from the Singapore General Hospital, and my co-chair is Sharon Chen, who's a very well-known mycologist. She's director of the Centre for ID and Microbiology Laboratory Services in Westmead in Sydney. Sharon, over to you.
Thank you, Ban Hock, and for your kind words. And I've had great pleasure in working with you for this initiative. So we're going to start off by a case presentation by Dr. Anupop from Siriraj University Infectious Diseases Unit in Bangkok. And this case report will be followed by a discussion by an expert panel who do not know the diagnosis, Dr. Chayakulkeeree, Dr. Beardsley, and Professor Chen from Taiwan. Dr. Beardsley is from Australia, and Dr. Chayakulkeeree is from Bangkok as well. This will then be followed by a detailed or entertaining literature review by two experts, Professor Chawarth and Dr. Tui Lee from Duke University. So over to Dr. Anupop. Thank you, Anupop. If you could present your case, we would be very grateful.
Okay, thank you, Dr. Ban Hock and Dr. Chen. So I will share my slide first. Okay, do you see my slides?
Yes, we're fine.
Okay, so good afternoon or good evening because we are different time zone. So I'm Dr. Anupop Chitmung, an infectious disease physician working at Faculty of Medicine, Siriraj Hospital. Firstly, I would like to thank ISHAM, ASID, and Asia Fungal Working Group for giving me a great opportunity to share an interesting case today. A lady with unexplained fever and weight loss. So give me a time. Okay. So today we have a 74-year-old woman. She worked as a farmer in rural Nan province for over 50 years, and she was in good health until April 2019. This photo shows a geographic area of Nan province, and Nan province locates in the northern Thailand, about 8 to 10 hours drive away from Bangkok. It's a bit far away from our center. On April 2019, this patient felt malaise, feverish, and productive cough for the past 3 weeks. She also experienced a loss of appetite, leading to losing 4 kilograms in weight. Afterward, she went to Nan Hospital to receive a medical assessment. At Nan Hospital, X-ray revealed lenticular infiltrates located in both upper lung regions. Sputum for acid fast and cultures were negative, while sputum for microbacterial cultures pending, and anti-HIV testing was non-reactive. So the physician prescribed her HRCE for suspected pulmonary tuberculosis at that time. Following anti-TB treatment for 2 months, her chronic cough was slightly improved, but she still experienced malaise and fever. She adhered very well to anti-TB treatment with no adverse event. Later, sputum culture came back for mycobacteria is negative, so she continued taking anti-TB treatment. At 3 months of anti-TB treatment, fever became more frequent and required daily acetaminophen. The patient noticed there were multiple painful raised pimples on her body. Physical examination at Nan Hospital, doctor found painful and reddish papules with tiny pustules on her arms, back, and legs, and they discovered multiple cervical lymphadenopathy and enlarged liver and spleen as well. Pus swab from skin lesions were negative for everything: gram, acid fast, modified acid fast, and cultures. So the patient was prescribed clarithromycin and ciprofloxacin. I think because the doctor at that hospital might be suspected like disseminated the NTM co-infection, something like this. After she receiving a combined antimicrobials for 4 weeks, she still had fever, productive cough, and unresolved multiple painful skin lesions. This is an CT scan of chest show multiple reticulonodular infiltrates, both lungs, and they were also like a consolidation predominant at the right lung as well here, and reticulonodular infiltrate on left and right lung. And moreover, another finding, the doctor also found swollen and painful pustular papules on the middle fingers. X-ray found osteolytic lesion at the middle phalanx as shown here, and they causing a pathological fracture in this arrowhead. There's a particle fracture from osteomyelitis. So she received debridement and on aluminum splint for immobilization, and the tissue culture center is no growth for bacteria. After this patient experienced a prolonged course of fever for several months with an unclear etiologies, that's why she was transferred to our hospital, Sirat Hospital in Bangkok. This is an physical finding at our hospital. The patient was alert but appeared weak and emaciated, and she got febrile. And we discover multiple enlarged lymph nodes in the cervical area. Size ranged from 0.5 to 1.5 centimeters. We also found presence of several red inflamed papillonodular lesions with pustules on her both arms, like shown in this photo. There's a multiple inflamed papillonodule lesion with a pustule on top of the lesions here. These are initial laboratory finding and radiographic finding. For the complete blood count, she got anemia and leukocytosis, and also thrombocytosis. For liver function tests, they were elevated globulin and alkaline phosphatase. For the micro testing, we repeat anti-HCV and it became non-reactive. And for the sputum culture, acid fast or PCR, TB, pus swab culture from skin lesion and blood culture, everything is unremarkable and negative results. This is an chest X-ray. There's still like a progress of infiltrate. There's a diffuse bilateral reticulonodular infiltrate on both lungs. So for the case summary, today we have a lady with unexplained fever and weight loss for 4 months with the multiple affected organs such as the bilateral reticulonodular infiltrates and also multiple papillonodular lesions with pustules on her body, especially both arms, and also we found multiple cervical lymphadenopathy, and last but not least, there's osteomyelitis at left middle finger. And so it's time for a panel discussion. My question is which causative agents are included in the differential diagnosis, and what diagnostic testing will you be considering for this case? And please discuss.
Thank you very much, Anupop. So may I invite the panel to offer their thoughts on these questions that have been posed by Dr. Anupop. Maybe Justin, you want to start?
Hello. Just wonder, Professor Chen or Professor Bradley, do you want to start first, or?
Why don't you start, Methee?
Okay.
Yep.
Okay. In this case, she had a prolonged fever for 4 months, and according to the history, it seemed that she may be in the immunocompetent condition, but I'm not sure, because some people have a hidden immunocompromised condition that we really familiar in some a syndrome in Thailand. We found some kind of this thing as well, like autoimmune disease that affect the immune. So if you look at the problem in this patient, she has bilateral reticulonodular infiltrate, multiple cervical lymphadenopathy, prolonged fever, and weight loss. And I agree with the initial doctor that he think of disseminated mycobacterium infection and most likely tuberculosis. But in disseminated tuberculosis should not occur in immunocompetent patient unless she has something hidden. And the second thing is, if you look at the skin lesion in this case, it looked like it's a pattern recognition that we are very familiar. It looked like the Sweet syndrome. It's like a pustule and also the erythematous patch, the raised erythematous lesion with the pustule. And this is actually the steroid lesion. Is immunological reaction, and we have seen in adult onset immunodeficiency or associated with interferon gamma autoantibody. And I think in Taiwan also prevalent in this disease as well. So the patient may have when they have infection, they could have the skin reactivation like this. But if you biopsy to the skin to send for culture, it would be negative because it's an immune reaction. It's not the infection itself. So this syndrome associated with non-tuberculous mycobacterium infection. So mycobacterium is possible. Second, fungus. So 3 of the fungal pathogen that is possible: Cryptococcus, Thalassemia, and Histoplasma. So can cause disseminated, chronic disseminated infection like this. And the lung lesion can be caused by histoplasmosis. But the bone infection is not it's not common in Histoplasma capsulatum, which is prevalent in our country, but it may be more common in African histoplasmosis that caused by Histoplasma duboisii that may have the osteomyelitis, but we did not see a lot of bone infection from Histoplasma, so not sure. Crypto and Thalassemia can infect the bone, can cause osteomyelitis. And the PAP pool, I did not see any like umbilicated molluscum-like PAP pool that compatible with dimorphic fungal infection in this picture. But maybe have to look for at the other part of the body. The third, it could be non-infectious disease like lymphoma or hematologic malignancy, but 4 months is probably too long. The patient should get worse before they came to our hospital. That's my initial thought.
Thank you, Methee. Justin?
I think you can hear me now. Sorry, I had some difficulty unmuting myself. I thought those were very excellent thoughts and a very detailed and comprehensive differential diagnosis. Of course, the first ever described case of Cryptococcus was a bone infection, so that could be a nice link, and I agree that there are some features that could be consistent. But it doesn't look entirely consistent with anything. Cryptococcus in any case would be easily excluded with a cryptococcal antigen test, which I'm sure has been already performed and will be revealed shortly. I agree that the skin lesions don't look typical for either thalassemomycosis or cryptococcosis, which are towards the top of my differential particularly given the fact that this is an Asian fungal working group meeting. The pattern on the arm almost looks sporotrichoid, I thought. So certainly not typical what we would expect, but I agree a biopsy would be informative to see the histopathological appearances. And I know that there's been culture performed on the swabs. I'm not sure if there were specific fungal stains performed on microscopy or whether there was fungal culture conducted. Given the long duration of the lung infiltrates, I think it would be worthwhile to get BAL to get some deep sampling done there. So far, we've only seen sputum samples, and potentially also a biopsy if that wasn't immediately revealing. This is a prolonged course, and certainly there are immunological and malignant differentials out there. So yeah, I mean, nothing else to add other than that. I suppose we'd always think when it originally did look quite a good story for TB that hasn't responded to first-line therapy, is this a case of drug-resistant TB? But all of the tests have been negative so far, so probably not that likely.
Thank you, thank you. Prof. Chen, Eugene, do you have no thoughts?
Yeah, I fully agree. The initial approach, based on the OH in Asia, we consider tuberculosis first because this is a chronic infectious process. I think we all agree this is we will consider infectious process first. It's similar in Taiwan. However, if no microbiology documentation and unsatisfied response after 2 months, we need to think about, is it tuberculosis? Especially when she referred to the second hospital, the tertiary care center, it is less common. You can see a data profile. There's a eosinophilia. It seems less common in patients with tuberculosis. This is my first impression. The second impression, the clinical presentation, we really will consider NTM. However, if we consider this is an otherwise healthy individual, although the age is elderly, but in the absence of immunodeficiency or any immunosuppression agent, we can do diagnosis approach, then consider if lab data support NTM, then we consider the NTM infection. But at the same time, we need to consider why she need intervention for NTM. That means host factor. This is a second hint. And this is case, as this webinar, we focus on fungus. So it is a typical case, demonstrate the underestimate the contribution of fungal pathogen in such kind of difficult to manage patient. So if referral to another hospital, we will conduct a very standard diagnostic stewardship. That means bacteria, mycobacterium, and fungus. Then we may earlier diagnose for possible fungal pathogen. Why? Because the clinical picture is more or less characteristic of thalomyces if patient is its patient. We are familiar with this presentation, primary skin and constitutional symptom and more chronic course. However, in the absence of characteristic underlying disease, we did not have direction. So if this patient consider tuberculosis, sometimes we can do the IGRA test. It's an immune assay, not just for to exposure to tuberculosis, to diagnose for latent TB. Our previous study showed that, and other study group demonstrate that if we do the IGRA test and the result is indeterminate, that will be the first hint of her underlying immunodeficiency. And then we consider adult onset immunodeficiency. Then all the management, the direction will change. This is my first impression. So I will do the fungal culture, including blood, including skin lesion, airway sample. In addition, consider thalomyces, then we will send for serum galactoma antigen assay, as there's a cross reactivity. This is my first impression. Thank you.
Thank you. Let's go back to Anupop.
Van Hoek, may I ask a question, a very quick one? I was going to ask Dr. Anupop if there's anything in the patient's history that gives the game away in terms of the diagnosis. I know this is it's a fungal session, and we in Australia wouldn't see histoplasmosis or Talaromyces, every week. It would be a lot less common. So, what is it that would give the game away as to the diagnosis?
Dr. Anupop or Dr. Methee? You probably have the most experience.
Okay. Could you repeat the question again, please? Sorry, I have some problem with the signal.
Oh, sorry. What is the biggest clue in the patient's history as to the most likely diagnosis? And I ask this question because for those of us who don't work in Thailand or in bits of Asia where you might see this disease, it's not every day that we come across this, and my initial diagnosis might have been sporothrix or disseminated candida. We've had one nice presentation from Cherie Gan in Singapore about spots that wouldn't go away. So what is it that gives away the diagnosis?
Okay, from my perspective, we have learned a lot from the adult patient that suffering from the disseminated infection, even they know any clue of immunodeficiency states. So that's why today we call adult onset immunodeficiency, because this patient presented with like some kind of disseminated infection from opportunistic pathogen. Particularly in the past time, we think of tuberculosis first because it's really common and can cause disseminated infection like this. But for decades ago, we found a lot of patients that presentation like this and infected with non-tuberculous mycobacteria, particularly rapid growing mycobacteria. And another case, we found a lot of fungal infection, particularly dimorphic fungi, especially Talaromycosis. That's why it look like a pattern recognition that we discussed. So this case, so we think if it's not responsive to any antimicrobial treatment, so we should think of fungal infection, particularly like Talaromycosis, because it's really common in like AOID or adult onset immunodeficiency in this case. So, but we have to confirm by the blood testing that we got like anti-cytokine antibodies, whether or not in this case, to confirm.
Yeah. May I add something to that?
Sure.
Okay. I practice myself about the clue. So I will consider two things. The first thing is exposure. Second is a clinical manifestation. So for exposure, sometimes it's hard to get the history of the exposure to animal or plants. For example, if histoplasmosis, you may get the history of exposure to go into the cave, exposure to the bat, that would be give you some clue that it could be histoplasmosis. But we always get the clue for that. And for cryptococcosis, most of the time we did not get any clue. Unlike in Australian experience, you may have the clue exposed to the eucalyptus tree, something like that. I'm not sure, but it's not always get the clue. For Talaro, it's hard because most of the patient did not recognize, and actually we don't know what is the habitat or the niche of this organism. So only histoplasma that you may get the clue. Second, the clinical manifestation, if you have lung involvement, that could be histoplasma or TB, the most common. Without CNS involvement, make cryptococcus less likely. If you have a patient with disseminated cryptococcosis, they should have CNS involvement. For bone, it could be NTM, Tararo, or crypto. That it's a combination of these. You give you what is the most likely, but in this case, it can be anything. I think. Yeah.
So thank you. I think we can get back to the story. Anupop, please.
Okay. So for the next story of this case, so for the progress of this case, we try to test for the serum cryptococcal antigen. It became negative. So for the lymph node biopsy, we biopsy from the cervical lymph node and tissue culture identify Tyromyces mannifii as shown in this picture, the colony red pigment colonies. And so this patient received amphotericin deoxycholate for 1 week and then switched to oral itraconazole. So we try to work up for the immunological testing in this case, and anti-interferon gamma autoantibody was positive. That's typical for this manifestation. And after she received antifungal treatment, and the patient recovered very well. And this is a follow-up Cherie at 4 weeks after antifungal treatment. It's remarkably resolved in this picture. All right, for the final diagnosis in this case, we have a lady with the anti-interferon gamma antibodies and disseminated tyromycosis. That's all for this case. Thank you for your attention and very informative discussion.
Yeah, are there additional comments from the panel? Eugene, it looks like you are right that after they got the diagnosis, they wondered why she was having disseminated thallaromycosis, and they went on to look for an adult onset immunodeficiency. You have some.
I would like repeat 2 very important lessons learned from these ladies. The first is we approach the patient usually based on clinical pattern, host factor, and environment factor. However, for this kind of we so-called TOCC, as Sharon mentioned, this kind of environment factor is very difficult to approach because we are not familiar with our environment. In addition, environment exposure can such kind of crypto and tyromyces histo maybe become latency, very similar to tuberculosis latency, and then reactivate many years later. If our audience have interesting, you can review a paper from Japan. They emphasize how difficult to diagnose the invasive fungal infection for return immigrant. The immigrant is stay in other continent, for example, Central or Southern America, where there's a so-called endemic mycosis. And the physicians in Japan are not familiar with this kind of endemic mycosis in other continents, and result in delayed diagnosis and less satisfied response. So in Taiwan, although we also diagnose indigenous histoplasmosis, although not common, but really we do have. So it is very difficult for physicians to remember everything. So I emphasize the standard diagnosis stewardship. Very similar to this patient when bacteria and mycobacteria were all negative. Very unusual. We should think about fungus. And the tyromyces is the most easily to diagnose. The full picture is very, we all familiar when patient with AIDS. And the microbiology, we can do the blood culture, skin, and airway. In addition, it's very easy. We can do the serum galactomannan antigen. It's very rapidly, because in many hospitals, including in Taiwan, lab is not familiar with mode other than aspergillus, for example, and the serum antigen will be quickly demonstrate some hint for this patient. This is two additional suggestions.
I just very quickly second those, or third, those comments about the difficulty of the epidemiological risk factors when we're talking about chronic infectious diseases. It's certainly the case with Cryptococcus that you tend to have your infection with the organism that you picked up often decades before. My experience with fungal infections particularly is that we often find the epidemiological link after the diagnosis has been made. And that's very interesting and satisfying for us as infectious disease physicians. But I think wondering about the exposures to trees or logging industries or bats or caves is kind of not very prospectively useful. It's just subsequently academically quite interesting. It's a great case as well for keeping an open mind about all the different causes of immune deficiency in adults, and that we don't just stop when we have a HIV negative diagnosis. So thanks a lot for including that in the case.
Okay, well, thank you very much, Dr. Anupop, and thank you to all the panel and the audience for your thoughts. And I can see questions in the Q&A, which we will save until the last bit of the meeting. So now we're going to have a treat in the next part of the meeting to talk about diagnosis and to talk about treatment. And our first speaker is Professor Methee Chayakulkeeree from Chiang Mai University in Thailand. So over to you, Professor Methee, for your talk.
Good afternoon, everyone, and good morning, Dr. Cherie from the US. And thanks the committee for giving me the opportunity to give a brief talk on characteristics of thalomycosis caused by Thalomyces mannefii. And this is a dimorphic fungi. In the 25 degrees Celsius, it is in the mold form, and it produces the red pigment, as you see here in the picture. And at 37 degrees Celsius, it's in the yeast form, which is a pathogenic form in the human. This organism was first isolated from the bamboo rat in Vietnam back in 1956, and the bamboo rat is the natural reservoir of this disease. The endemic area is confined in Southeast Asia, particularly in Thailand, in Vietnam, Southern China, Hong Kong, and India. The number of cases varies depending on the amount of rainfall. As you see here in the picture, the red line is the amount of rainfall. This is the rainy season in Thailand, start from May up to September. And the number of cases of thalomycosis increased during that period. Why the cryptococcosis is not affected by the number of the rainfall. In Thailand, thalomycosis was emerged right after the HIV epidemic in 1984. And this is the number of cases recorded at Chiang Mai University, which is located in northern part of Thailand, where is the endemic area of this disease in Thailand. The number of cases declined right after the HIV preventive strategy and also nationwide antiretroviral treatment. The red line is the number of the cases recorded in the paper by Dr. Cherie up to 2009. That is in the way of the increasing number of the cases in Vietnam. The clinical manifestation of thalomycosis in people living with HIV/AIDS. This is very familiar for those who practice of HIV/AIDS and living in Southeast Asia. There are many literatures report of characteristic of thalomycosis in people living with HIV/AIDS. And here I provide for 4 cohorts from Thailand, from India, from Hong Kong, and from Vietnam, which comprise of the largest number of patients in the series. And the study conduct from like 1987 and up to 2009. You will see here that majority of patients are men than women. This correspond to the opportunity to expose to the soil for men than women. The median age is around 25 to 30 years old. Move to the part of manifestation. It is believed that the pathogen is transmitted by inhalation of the spore and spread to various organs and cause signs and symptoms of those organ involvement. The majority of patients have fever, anemia, weight loss, and also the skin lesion was found to be above 50%. Other characteristics may be found at lymphadenopathy, hepatosplenomegaly, and respiratory symptoms. And this image shows skin lesions such as nodular lesions and central necrotic papule, or we call umbilicated skin lesion. And ulcerated nodule have also been described. The skin lesions are distributed over the trunk, the extremities, the back, the face, and sometimes in the mucous membrane, as you see something like here, umbilicated skin, umbilicated lesions at the mucosa like soft palate. However, central necrotic lesion is not specific for thalomycosis. This lesion need to be distinguished from cryptococcosis, histoplasmosis, and sometimes molluscum contagiosum. The easiest bedside method to make a diagnosis is to scrape skin lesion and perform dry staining. This slide shows pleomorphic yeast cell with binary fission. I will make it closer. This picture demonstrates binary fission clearly. That is the way how this organism reproduction, with different from histoplasmosis and cryptococcosis, were reproduced by budding. The investigation showed low CD4 count, low hemoglobin level, white blood cell count, and have transaminitis. Various clinical specimens can demonstrate thalomyces mannefii, but the yield of diagnosis is high with the blood culture, like over 75%, skin scraping or biopsy over 90%, lymph node is over 80%, and also bone marrow if the patient have pancytopenia and that is bone marrow involvement is approaching 100%. And people living with HIV/AIDS may have concurrent opportunistic infection, including oral candidiasis and tuberculosis. Move to the comparison between people living with HIV/AIDS and patients without HIV infection. We did a retrospective study to compare the clinical features between people living with HIV/AIDS and patients without HIV infection from January 2007 to December 2011. And we found the clinical feature between these two groups are pretty similar, except for patients with patients without HIV infection are less likely to have fever compared to people living with HIV/AIDS. In the other way, like you see in this patient, bone and joint infection is more commonly found in patients without HIV infection if compared to people living with HIV/AIDS. And the skin lesion, we found that people living with HIV/AIDS have the umbilicated skin lesion than patients without HIV infection. In the other way, we found Sweet syndrome in the patient without HIV infection than people living with HIV/AIDS. The mortality between two groups are not different. For the laboratory findings, people living with HIV/AIDS demonstrate leukopenia, thrombocytopenia, low CD4 count, and have transaminitis. And this is to point out that people living with HIV/AIDS have higher proportion of fungemia if compared to patients without HIV infection. In this cohort, 35% of patients without HIV infection here had underlying diseases, for example, diabetes, lymphoma, and colon cancer. However, 65% of the patients without HIV infection had unknown underlying diseases. At Chiang Mai, we start to see a rising number of the patients with impaired cell-mediated immune response, similar to people living with HIV/AIDS but non-reactive to HIV tests. The opportunistic infection in this group looks similar to people living with HIV/AIDS, except for non-tuberculous mycobacteria, that the patient with people living with HIV/AIDS have more see more common of MAC, while the patient with without HIV infection have rapid grower mycobacteria. And finally, the underlying pathogenesis of CMI defect in this group of patients are related to anti-interferon gamma antibody that we call IGA. So we continue to do the 2012, that is continue from the previous cohort up to June 30, 2021. And this is in the, it's not yet published. What we found here is almost similar to the previous study, that the patient who have with IGA are older. The mean age is around around 55 years old, whereas people living with HIV is about 30 to 40 years old. The patient who have HIV infection have more likely to have concurrent opportunistic infections. For other clinical features, people living with HIV/AIDS are more likely to find like constitutional symptoms, for example, fever, fatigue, weight loss, more than people who have antibody to interferon gamma. But I would like to emphasize again that is concordance with the previous study, and also you see from this case presentation, the bone and joint infection are more likely to be found in the patient with antibody to interferon gamma. The other difference is in chest radiography, that we found that interstitial infiltration are mostly found in people living with HIV/AIDS, whereas the people with antibody to interferon gamma, we found alveolar infiltration and also pleural effusion. How about the outcome? For the patient who receive antifungal treatment, but mostly this number are from the patient with HIV infection is about 10 to 30% despite antifungals. But I have shown you earlier that the comparison between patient living with HIV/AIDS and patient without HIV infection, the mortality rate are pretty similar. The poor outcome was not different between that two groups. And this is a study done by Dr. Cherie Gan. The factor associated with poor outcome include intravenous drug use and respiratory symptoms such as dyspnea. For the rest, like skin lesions and history of fever are the protective factor of the poor outcome, which can be explained by the fact that skin lesions and history of fever may catch or call attention from the physician to make earlier diagnosis and treatment than those who have no skin lesion and history of fever. So I would like to summarize here that constitutional symptoms are common in people living with HIV than people who are not HIV infection, in particular anti-interferon gamma antibody. However, the clinical features are difficult to distinguish from other mycobacterial diseases or other invasive fungal infections, such as cryptococcosis or histoplasmosis, as I mentioned earlier. Umbilicated skin lesions are often presenting signs that we found over 50% of the patients with HIV infection have this skin lesion. However, this skin lesion is not specific from tuberculosis. Patients without HIV infection are less likely to have umbilicated skin lesion and fungemia. And I would like to say that recently, most of HIV uninfected patients are patients who have antibody to interferon gamma, and the skin lesions are mostly squeeze syndrome, as we found in the presenting case. So the last comment is that the physician who take care of patients in endemic area or returning traveler from endemic area should be aware of this disease if clinically compatible with tuberculosis. Thank you.
Thank you very much, Dr. Chaiwarth, and for that very comprehensive and very clear summary of how patients with tuberculosis may present. We'll take questions at the end, and I might hand over to Ban Hock, my co-chair, to introduce the next speaker.
Yeah, thank you very much, Sharon. So I think it's a great pleasure to have someone from outside the region who has made a great effort to join us, even though she's 12 hours behind. Dr. Thuan is Associate Professor of Molecular Genetics from Duke. And welcome, Dr. Thuan. We're looking forward to your talk.
Thank you very much, and good afternoon, evening, everyone. Let me share screen. Well, first, thank you so much, Dr. Romani, for such a fantastic overview. You make my job very easy now with your very nice overview of the clinical manifestation, particularly between HIV and non-HIV patient, which is really important for trainee and fellow who have little experience in these cases. So it really make my job easy now just to think about a new strategy for diagnosis and management. But I will also touch on the epidemiology a little bit, because I think hearing from the discussions and the exposure history, I thought it would be good to talk a little bit about epidemiology too. So I've been sort of fixing my slide as I go. Can you see my slide, my screen?
Yes, yes, thank you.
Okay, make sure that it's at the... Okay, so the microbiology has already been touched on, but I wanted to just mention that it's produced a very bright red pigmentation in the mole form, and really is not Talomyces monefii unless you see this red pigmentation. However, red pigmentation is not unique to monefii. There's a few other Penicillium and Talomyces, maybe 2 or 3 others that produce red pigmentation. But if you don't see the red pigmentation in the mole form at room temperature, it's not Talomyces. So it's very, very important for the consideration of thinking about the pathogen in the microbiology lab. In the mole form, it looked like a fan, beautiful fan, different than Aspergillus, which looked like a sunflower. And in the yeast form, as Dr. Romani said, it's very much different than other yeast in the way that it's produced by like a bacteria with binary fission. So if you can see this beautiful midline septum, you really make the diagnosis on the microscopy without waiting for culture, because Pisto has the same size, about 2 to 3 micron, intracellular, extracellular looking yeast, very similar, but Pisto is a budding yeast, and this one is a binary fission yeast. So if you could identify that in a microbiology lab, you make the diagnosis. Talomyces is now one of the 19 WHO fungal priority pathogen list that was published in 2022, and Dr. Justin Beasley has done an amazing job of putting the data behind this to come up with this list. And this has really changed the game very much for the field, because it's been very neglected, as you all know. in terms of research, development, awareness, and many things, diagnosis and treatment. There's many things that we can do to improve this particular fungal infections. And so I'm glad that it's on this list. The geographic distribution, as you all know, it's really endemic in most countries in Southeast Asia, including this side of the Pacific, but basically very much and hyper-endemic in Vietnam, Thailand, and southern China. And I wanted to draw your attention to other endemics, because I think for the case that you presented earlier, if the patient had come from North or Central or Southern America, then the diagnosis would have been expanded to include other disseminated endemic mycoses, such as blastomycosis, histoplasmosis, obviously, that we see in Asia as well. Emerging mycosis that pretty much in South Africa, and then sporotrichosis, disseminated form, can also look very similar to the patient that you presented. Coccidiomycosis, paracoccidiomycosis, also in a disseminated form, can be very similar to these patients. So it really, the geographic distribution would expand your thought in terms of other endemic mycoses that could present just like this particular case. Interestingly, Talomyces mannefii is close to phylogenetically with Aspergillus. So it's very similar to obviously other penicillia. And as you all know, that it used to be called Penicillium mannefii, but in 2011, with sequencing and a lot more sequence data, it became apparent that it's actually phylogenetically clustered with Talomyces. So it was separate in its own phylum here, but it's very similar to Penicillium and Aspergillus, whereas the other endemics, Histo, Blasto, Cocci, Paracocci, and Sporo, are in a different order of fungi. So really interesting, and this come to the comment earlier, one of the panelists from Taiwan, I didn't catch the name, but basically he was saying that galactomannan from Aspergillus cross-react with Talomyces, and that is true. So the emergence of Talomyces really driven by expansion of uncontrolled HIV infection, right, as you have heard, and then immunosuppression of all sorts of forms. Chronic diseases, we've been now seeing patients who doesn't have the classic immunosuppression issue. They have like diabetes, chronic kidney disease, chronic lung disease, certainly in cancer, particularly cancer, hematologic malignancy, etc. And then also there's an issue to be recognized is with travel, right? With global travel and migration, you're going to have people who come from this region who live in other parts of the world. So you have to really put that in consideration. And the disease is not like Aspergillus, where seem to be an acute sort of exposure relationship, whereas here there's a latent reactivation of latent infections. You have to be thinking about where the patient's from and their travel history. There's obviously very similarly with other fungal pathogens that are environmental pathogens, any manipulation of soil, any sort of encroachment into the natural habitat, and certainly temperature with global warming. All these are very concerning because we know fungal pathogen has the capability, already about 200 of them out of millions are able to invade warm-blooded hosts. So as the global warming go up, these pathogens will really have capability of adapting to stress, to particularly heat stress. And we know that have been demonstrated numerous times in Cryptococcus, in other fungal pathogens that are able to invade warm-blooded hosts. There's a very tight temporal relationship between HIV and chylomycosis, as Dr. Romani had already mentioned. So this is an epidemic curve in Chiang Mai, very similar with the HIV epidemic here in southern Vietnam in Ho Chi Minh City, and here in southern China. Actually, the epidemic in southern China is we're not is much more, how do I say, robust compared to Thailand and Vietnam. As of 2017, and actually the last few years, they still see more than 200 cases per year at this one particular hospital in Guangzhou. And Guangxi is the same. So in southern China, we see much more of a thalomycosis problem. And in this particular study from Guangxi, which is another major province in China, southern China, that is very endemic for thalomycosis. Thalomycosis in blue here, mortality is very high. So you could see 50% mortality by about 2 to 3 months here compared to mortality due to other opportunistic infections, including TB and cryptococcal meningitis. So it's a pretty substantial, sizable mortality in patients with HIV. And it makes up about 16% of inpatient HIV hospitalization. Now there's certainly an emerging awareness and also incidence of primary immune deficiency being recognized because of our ability to make better diagnoses, make genetics, diagnose genetic mutation and underlying innate immune deficiency problem. So in adults, as you know, there's interferon gamma autoantibody is a most common condition we see associated with thalomycosis, but also hyper IgG or Job syndrome in these people recently have been shown by Steve Holland from NIH that the IgG Job syndrome actually associated with STAT mutation. So again, STAT mutation does cause problems that lead eventually to reduction of interferon gamma production. And so everything sort of pointed interferon gamma or Th1 pathway being a major defect that will put the patient at risk. In children, we see thalomycosis in early age, in hyper IgG syndrome, in SCID children, CVIDS children, in aplastic anemia, in people with functional defects in interferon gamma or IL-12 pathway, and certainly in mutation that I mentioned, particularly in the STAT pathway. For secondary immune deficiency, there's typical immune deficiency that you are all very familiar with. So autoimmune disease, in lupus, these patients predominantly get immunosuppressive medicine, and that's probably not so much the autoimmune disease that put them at risk, but the immunosuppressive medication that they are on to suppress the underlying immune disease that put them at risk. Malignancy, we do see in solid organ malignancy like lung cancer, colon cancer, buccal cancer, etc. And then also we see in solid organ transplant, particularly renal in Southeast Asia, probably because we see a lot more renal transplant than other transplant yet. And we see some patient with hematologic stem cell transplant, although it's not very common for some reason. Stem cell transplant people are not, as we think, at risk for endemic stomatosis. And then there's a typical emerging risk factors, which include, as I mentioned, chronic diseases like cirrhosis, COPD. People with chronic COPD and lung disease are at risk for chronic thalomycosis, pulmonary thalomycosis. People with diabetes, pulmonary TB, very much like aspergillosis, chronic aspergillosis disease that kind of gets settled in these cavitary lesion of old pulmonary TB lesion. And interestingly, there's several reports of people who treated with novel anti-CD20 monoclonal antibody, rituximab, and JAK inhibitor. And these you don't think a traditional T cell deficiency. It's basically B cell depleted medicine, but patients still at risk. So that's something to be on the lookout for, particularly when we talked about treating these patients, particularly with the interferon gamma autoantibody with CD20 monoclonal antibody. It also can put them at risk for disease. The global burden estimate has been challenging, and we are working hard to trying to get this done, because I think people won't recognize our disease unless we have a global burden estimate. So we really need to have work together on a global burden estimates to really bring attention in terms of research and development for the disease. So essentially, as I said, we did this study with Dr. Ning from Guangxi Medical Center, and he basically did a systematic review and showed that we had about 25,000 cases published in the literature. These are non-replicate cases in 33 countries. The majority of HIV infected, majority are male, and that's likely due to the HIV demographic more so than male being more susceptible, I don't think. Although we don't know that. Children as young as inborn can be infected, and that's probably from maternal and fetal transmission. China, Thailand, and Vietnam, as I mentioned, bear the most burden of the infection. And we estimate based on culture positive alone, which I will tell you, a little bit missed a bunch of patients. There's about 18,000 cases and 5,000 deaths per year. And this is very much, I think, an under diagnosis problem. We estimate just based on culture positive disease alone and the epidemic of HIV, particularly in southern China, where you do see increased incidence of AIDS, in particularly MSM population, we estimate that there's going to be an increased incidence by 2025. This is actually now out of date, but we need to do this projection. And this only really predominantly driven by HIV incidence. So we haven't even talked about non-HIV. I added these slides because we discussed about the environmental and exposure risk factors. And Dr. Romani mentioned already this work done in Thailand, where they really kind of cluster all of these cases over 4-year window and by month. And as you could see, thalomycosis here had a very seasonal aspect here between about June and September. You see about 50% increase in incidence in the rainy month, and that's go very alongside with the amount of rainfall in the region in the summer. So it's very nice association here, but not cryptococcus. In Vietnam, we see the same thing, and this is a different analysis where Marcel Wolbers, a statistician at Oxford, who helped me with this analysis, where we could see these are actually the actual number of cases, and you can see this beautiful sinusoidal shape that happened in the rainy season. So we see about 30% increase in cases. And when we look at really what weather factor driving this, is it rainfall, is it humidity? What we found is actually not rain or wind speed or temperature, but actually humidity is the independent risk factor. So it's actually humidity in the rainy season that is driving incidence, not so much precipitation. We know that there's 4 species of bamboo rats in the region, and we know that thalomycosis incidence track along with where the bamboo rats are, but there's actually no evidence of bamboo rat to human transmission. When we look at the bunch of field study looking at prevalence of thalomycosis in bamboo rats, and you could see from 10% to almost 100% in China, Thailand, and India, the prevalence in wild bamboo rat running around without any symptom, or without being sick, is very high, and it's in the liver, spleen, and the lung. So the question is whether they serve as an intermediate host, not so much the obligated host, but they are another warm-blooded host that can propagate the fungus in the environment. There's 2 case control studies, one done in Thailand and one done in Vietnam. We still need to publish this work. And basically 2 studies in 2 very different geographic areas. Thailand is very much in Chiang Mai, which is semi-rural area, whereas in Vietnam was done in southern Vietnam in Ho Chi Minh City. So very urban setting. We saw the same thing, that risk factors for thalomycosis is exposure to plants and farm animal. In other words, soil exposure rather than exposure or consumption to bamboo rat. And the odd ratios are exactly the same, which is remarkable because the sample size are very different. So remarkably, it's soil exposure seems to be the issue. Another thing we did, which I thought was really interesting, was to look at actually geographic distribution of case versus control. This is the first time when we actually have control. This is 200 case and 400 control. So it's a big study. And what we did was we mapped case versus control by region. And this map, just to show you, the yellow are the highland area of Vietnam. 2/3 of Vietnam are made up of highland area, mountainous region. And the study was done in Vietnam, southern Vietnam, so ignore the north for now. But if you look at case by region, and with dark blue being the higher number of case, when you look at case by region, it's kind of clustered around here. The control is kind of everywhere. But if you do case and control ratio, and our study is 1/2. Sorry, my dog is going crazy. But case out of control should be 1:2, so it should be 0.5. What you see here is that in the mountainous area, tracking with the mountainous region of Vietnam, this is the central highland area, the ratio of case versus control is much higher. 3 to 5 in the mountainous area compared to, say, the lowland area of the Mekong Delta of Ho Chi Minh City. So this tells you within the endemic region, patients who come from the highland area are at much more risk. So here's an odds ratio at higher risk, 3 times likely the risk of developing disease compared to those who come from the lowland area. And we went back and asked people about previous resident travel history, people who come from the lowland area who have ever traveled to this area have 4 times the odds of developing disease. So even in the endemic region, we know that geographic is a risk factor. So I think that that's really interesting work we need to publish. The ecology of Thalamyces is, we think after all of that epidemiology, you think that it's probably fungus has a very niche area in the mountainous area. And it probably take advantage of the bamboo rat to amplify itself because it doesn't survive very well in the soil. Because of the competition in the soil, there's a lot more soil fungal pathogens, but just like Aspergillus fusarium and other that are much fast growing and compete much better for nutrition because they grow much faster. Whereas Thalamyces histo, etc., grow much slower in a different metabolic way. So they have to compete for nutrient. And by changing to the yeast form, they basically put themselves at an advantage spot where they can amplify much more efficient in the yeast form. And humans and bamboo rats get infected. We are kind of a bystander host by inhaling this spore. And that's why when we travel to these regions, or if you come from these regions, you're much more likely at risk for infection. I have to give credit to my little teenager daughter who drew this digital thing for me. In terms of disease spectrum, we know that inhalation, there's probably an acute infection form, and very much like cocci and other endemic, there probably is an acute respiratory infection form that we don't know about because we don't even think about, and we don't have a diagnostic, and we don't know whether it's sort of resolved spontaneously or the patient do have some acute respiratory symptom. We have no idea. The only reason we know that cocci caused acute pulmonary infection form is because there's an antibody test. And so there needs to be diagnostic to improve our understanding of the disease spectrum beyond the disseminated form. So in patients with non-HIV and immunocompromised, they can develop localized infection predominantly of the upper and lower respiratory tract, and also bone, as we mentioned. And in bone, it's interestingly, in non-HIV, but not so much in HIV, it's called lytic lesion here, and it can cause pathologic fracture, as the case that was presented to us. And very much in patients with disseminated infection or profoundly immunosuppressed patient, you see dissemination beyond the lungs to disseminate through the reticular endothelial system involving the lymph node, the liver, the spleen, the bone marrow, go to the skin, and spill to the bloodstream, etc. And so there's much more prevalence of fungemia. About 50 to 70% of patients at late stage of infection will have fungemia and can be diagnosed that way. That's why non-HIVs has very difficult because it's kind of localized and you have to be thinking about it. You have to stick a needle in to get a biopsy. So much more challenging to diagnose. You have to think about these people because of the non-disseminated nature. And so this is a study published very recently by your colleagues at your hospital in Bangkok in 74 Thai patient and 19 US patient with anti-interferon gamma autoantibody. And there's slightly different type of infection that cause disease in those people. So in Thailand, Mycobacterium abscesses and other rapid grower are predominant, but in the US, it's the MAC, Mycobacterium avium complex that cause disease for mycobacteria. You could see there's a whole slew of other pathogens here, including, Myloidosis, Salmonella, Cryptococcus, Phalomyces, and TB, as well as VZVs and other viruses. So there's a whole slew of different pathogens that infect these people, not just Phalomyces. And a lot of them involve bone, lymph node, and lung and skin. And the probability of having an opportunistic infection increase, so this is probability of infection, increase with high titers. So these are the titers. As you go up on the titer, the probability increase. And we know that the antibody level over time, this is in Thai cohort over 7 years now, and the US patient up to about 15 years, they really don't go away. They fluctuate, but they don't really go away. And despite treatment with rituximab for some patients, cyclophosphamide and others, they come back. It's very short-lived. And so this is a really challenging issue. And it's really unclear what really triggered these autoimmune issues, whether it's a pathogen that triggered this molecular mimicry that's causing autoimmune disease, and then it's kind of a cycle, vicious cycle of pathogen trigger autoimmunity, and autoimmunity causing, because it inhibits interferon gamma, that it puts you at risk for persistent infection with these pathogens that you are exposed in the first place. So it's a very challenging clinical problem to talk about. So diagnostic challenge, even for patients with advanced HIV disease, is that it's very subacute. In our study, we found that patients can have symptoms for up to 6 months, and they can be, come in the hospital with fever of unknown origins, and just like the patient that we described, for months and months, and culture up and down negative. So they get antibiotic and they get TB therapy. They don't get better until they got dissemination, like our patient that presented, skin lesion developed and blood culture positive. By then, they're very sick. Again, you can make a quick diagnosis with skin lesion with a skin smear, but culture takes time. And blood culture in HIV patients is positive in about 50 to 70% of patients, much lower in non-HIV patients. And so that represents a very challenge. It does take up to 28 days to grow. Previous study just grow them from, for 14 days and say up to 14 days. But now we've done microlytic fungal blood culture in our study, and we found that you pick up about 25% more telemycosis with fungal blood culture that you keep for 6 weeks. So you missed a bunch of cases as well, telemycosis with low fungal burden. It's really important to do fungal blood cultures. In terms of diagnosis, I'm looking at time here. Diagnosis, as you go, obviously, the easier you, microscopy and cultures are the gold standard and remain the gold standard, but it takes time, right? And so I think we need to do better at stretching diagnosis this way, getting genomics involved, antigen, post-transcriptomic, serology. It's going to be easier. The confidence reduce when the diagnosis become easier. However, I think we need to really combine for fungal infection and not just stuck for microscopy and culture. We need to push the agenda for genome, antigen, post-transcriptomics, and antibody tests. And a combination of these can really improve diagnosis and not just relying on microscopy and culture, where we are right now. So we do have a tropical medicine research center for telemycosis funded by the NIH about 2 years ago. And the goal is really to work together in the region with partners, academic industry partner, to advance a pipeline of non-culture-based diagnostic for thalassemia. And so we, with the goal to reduce incidence, reduce mortality and prevention. And we have a pipeline of real-time PCR assay, antigen detection assay, by enzyme immunoassay, by LFA, lateral flow. There's an assay from Thailand, Chiang Mai here that is being developed by Professor Young Chim that we're going to validate. We are developing an LFA with IMI, which is a company that developed the LFA for crypto, using the same antibody test. We are using an EIA currently, an evaluated diagnostic utility in clinical practice, and we are testing PCR. So hopefully in 1 or 2 years' time, we can get these diagnostic in commercial and get help. And this host-based assay too, and for the reason I mentioned, we need to understand the entire spectrum of disease, not just disseminated disease, not just pathogen-based approach, but also host-based approach, particularly to understand people who are undergoing chemotherapy or immunosuppressive therapy. We wanted to know whether they've been exposed and that whether they need primary prophylaxis or preemptive therapy to prevent infection. So all of these diagnostics need to be worked on for us to improve understanding of disease. I'm going to skip very fast. The PCR assay that we have developed here is really promising. In 100 patients, 102 patients with fungemia, it pick up 101. So 99% sensitivity. In 36 patients without fungemia, it pick up 20, so about 56%. So it actually pick up people without blood culture positive. That's fantastic. And overall, it's 88%. So there's very promising PCR assay. The in-house EIA assay is based on MP1P gene that has been discovered by Professor Ki Yuan and Jasper Chen from University of Hong Kong. Fantastic team of researchers who did some fantastic basic science research, identified this MP1 protein here, which is a fungal antigen protein released in abundance in the bloodstream and urine of patients that can be picked up by monoclonal antibody. There is a commercial assay in China that was approved about 2 years ago, but then they stopped producing because of COVID and reduced need. So I'm sad about that. This could have been fantastic. The performance of the commercial assay compared to our EIA in-house are very similar because it's used the same antibodies. As you can see here, it differentiates case and control beautifully in the plasma with very nice ROC curve. About 96%, it can differentiate between disease and no disease. And in the urines as well, 96% performance. And the key here is that the the commercial one in China, and the in-house assay from Hong Kong really pick up disease 96% sensitivity compared to blood culture of 67% in the same compartment of blood. So I think this is fantastic news because it's really much more sensitive. So pretty soon, hopefully, we can replace the galactamin and cross-reactivity test with this TM-specific antigen test that could be commercially available soon. There's 3 point-of-care tests. One IMI test that I mentioned, the University of Chiang Mai, Thailand test using slightly different monoclonal antibody, slightly different setup. And then there's an assay that we're developing at Duke that allow pretty much a single-handed, you put it in and it can tell you positive, negative, but it actually also measure the fluorescence intensity. So give you quantitative level of antigen as well, which I'm very excited about. So I think quantification of antigen, not just positive or negative, is very important for this disease. I'm going to skip through the performance of the LFA because of interest of time. I want to give time for a question. Skip performance of the Thailand LFA. So far, everything looked very promising, but we need to validate in a huge sample patient cohort in a prospective manner. And that's what we're going to do. And hopefully in a year or so, we're going to have the result. And the idea for these antigen diagnostic is that you can screen people at time of dissemination. And very much like for cryptococcal disease, maybe if they screen positive, you can provide preemptive antifungal therapy, itraconazole in this case, which will then interrupt disease development. And that would be a very effective way to prevent disease. Instead of giving fluconazole or itraconazole for primary prophylaxis to everybody with low CD4 count, we can do this kind of a diagnostic-driven approach to disease prevention, which I think is going to be a game changer for this disease. Quickly about treatment, you all know about this New England Journal paper that we published comparing itraconazole and amphotericin B for induction therapy. Prior to the study, there was no data to tell which medicine is better, and was data case theory suggests that they are similar, and indeed they're similar in the first 4 weeks. Until we follow patient for 24 weeks, 6 months, you could see the Kaplan-Meier curve split with excess mortality in the itraconazole induction therapy group. And this is really due to relapse and IRIS and etc. So clearly, there's evidence that now we should not be using itraconazole on any patient with disseminated thalomatosis. Mortality reduction is 50%, so that's substantial. And when we look at heterogeneity between people of different disease severity, there's absolutely no difference in terms of the treatment effect based on disease severity. So again, this speaks to the fact that we need to treat with amphotericin B induction and hit hard, hit early for people with disseminated thalomatosis, regardless of disease severity. This study, we basically did quantitative fungal culture in patients in this clinical trial, and you could see amphotericin B reduce fungal clearance dramatically. And by day 8, they almost clear on everybody compared to itraconazole, only clear in 60% of patients. So clearly, the drug worked very differently in terms of fungal side effect. And this is really important. And we really have data to show now that the rate of clearance is associated with mortality. So it's very important that we have now kind of a biomarker to delineate treatment effect beyond mortality. So hopefully in the near future, they're going to be therapeutic coming on the market that we can evaluate using early fungicidal activity rather than mortality, which is require huge clinical trial. So maybe you can advance therapeutic in early phase clinical trial using just fungicidal activity alone. I'm going to quickly talk about a novel antifungal susceptibility testing method that we developed using Alamab-Lu to really assess antifungal susceptibility for thalomycin. Such a method does not exist. And what we've done, we published in Medical Mycology, what we have done is look at 60 clinical isolates and look at all the conventional antifungal drug, and you could see amphotericin B sits here with the MIC of 0.5 and 1, which is classic for all fungi. You can see that flucytosine, interestingly, have very good activity for thalomycin. It's actually higher MIC for it's about 0.5 to about 8 for crypto, so much better for thalomycin. Flucytosine doesn't have activity for other endemics, not that I'm aware of, not for histo, not for cocci, but for thalomycin. So this is very interesting. Itraconazole, voriconazole, posaconazole certainly are very good for thalomycin, and there's evidence that voriconazole can be used very well for induction therapy. Although I would say there's not a clinical randomized trial, so I wouldn't say that voriconazole is the same as amphotericin B. I would still advocate for induction therapy with amphotericin B followed by vori or azole drug. And then you could see fluconazole doesn't work very well with high MIC, and the echinocandin don't work very well. Interestingly, the new drug on the market, fosmanogepix, looked like very low MIC. Oteseconazole, very low MIC, even lower than the other azole drug. Oteseconazole is a 4th generation azole drug. Olorifim, again, very, very low MIC. Ibrexafungerp is really interesting too. It has very broad range and kind of in a susceptible range. So this is really exciting that you got new drug and flucytosine that potentially can be used in the future, in the near future. to look at treatment for thalomycosis, not just azole and amphotericin. So this work in our lab that we are going to submit soon to assess for synergy between M4B and 5FC, and we show most isolate had evidence of partial synergy, not full synergy, but when we did time Q curve, there's evidence of full synergy with amphotericin B and 5FC when M4B is used at a sub-MIC level. And this is really important. I think this is why 5FC and M4B synergy work for crypto, because M4B doesn't penetrate the brain very well. And it actually, its level in the brain is lower than the MIC. And so I think in this setting, 5FC worked beautifully for M4B. And this means that there's much work to be done in terms of evaluating combination therapy, particularly for these deep-seated infections, when it's not just like Candida in the bloodstream, it's deep-seated in the liver, spleen, bone marrow, in the CNS compartment, that there may be a role for combination therapy to augment antifungal efficacy. And we are now funded to do this trial. It's going to be a 7-year clinical trial called LAMFAST, evaluating single-dose liposomal M4B compared to 2 weeks of deoxycholate, and compare with and without 5FC. So this is going to be a fun study, and I hope to be done in multiple countries, including Thailand, Vietnam, and China. Take-home message is that we should consider thalomycosis in patients with subacute onset of fever, constitutional symptom, respiratory tract symptom, and lymphadenopathy. And the laboratory abnormality you see very frequent is cytopenia, hepatosplenomegaly with elevation of transaminitis. Fungal cultures of blood and clinical specimen is very important to do. And we hope very soon we would have an antigen real-time PCR assay that can speed up the diagnosis. These assays, some of them are very good sensitivity, and both of them had very good specificity. So they could serve as a rapid rule-in test that would substantially improve the diagnosis, but also there's a role for screening, as I mentioned, in asymptomatic people. Urine provide an excellent sample for antigen tests. I didn't show you the data. And all of these diagnostics need to be evaluated in non-HIV patients. Treatments, M4B induction therapy save life, so I would advocate for M4B. And the question is, can we do better with combination therapy with 5FC? Can we do better with single dose, high dose liposomal M4B to reduce toxicity due to the 2 weeks of deoxycholate M4B? This trial going to be done. So hopefully in the next 5 years, we're going to have the result. M4B and other fungal cell wall agent, I think there's a place for them in the future. And in terms of prevention, I think there's a diagnostic-driven approach for primary prophylaxis, which I think is very effective. In the 21st century, we should be doing diagnostic-driven prevention and not blindly put people on antifungal prophylaxis. And then there's an issue of when to stop secondary prophylaxis. We need to evaluate that too, because right now, for HIV, we keep it until CD4 counts above 200 or 150 or 100 forever. And that can be 2 years, can be 1 to 2 years long, which is very long, costly, drug-drug interaction and toxicity, and drug resistant, right? Azole resistant problem. So if we can stop early with kind of a viral load guided therapy, that would be better. So I thank you so much for your attention, and I'm sorry we run out of time, but I tend to talk a lot. I'm sorry about that, but thank you for your attention.
Thank you very much, Thuy. That was amazing, and we certainly have learned a lot. We do have a few questions, so I'm going to take the chairwoman's prerogative and extend the session a bit. Just going through the chat and the Q&A, there are questions for anyone, but I might direct this one to you, Thuy. Could you elaborate on the ideal duration of treatment for thalomyces, and also if there's a role for voriconazole?
Yeah, so I mentioned about those very, very quickly. duration of therapy, certainly there's an induction therapy right now for 2 weeks, followed by consolidation for 10 weeks with itraconazole at 400 milligrams, 200 milligrams twice a day. One thing about itraconazole is that you need to make sure the patient take it with food, because absorption reduced substantially from 60% to like 20% without food or without an acidic drink. So that's a problem with itraconazole. And then after the consolidation of 10 weeks, you put the patient on maintenance therapy, 200 milligram, until their CD4 count rises above 100 and maintain over 6 months. And that recommendation of CD4-based duration is really based on a case series of 30 patients in Thailand where they follow patient. And when the CD4 count rise, nobody relapsed for over 6 months with CD4 count above 150 or something like that. And so that was not a randomized study. We've never evaluated in a randomized control trial to say when is it safe to stop maintenance therapy. I think when the patient, after 6 months of therapy, I fully believe that obviously we need to do a clinical trial. And as part of the LAMFAST trial, we're going to do that, is to stop therapy after 6 months when they're biologically suppressed. We believe that biological suppression is a much more important biomarker of immune susceptibility to these fungal infections than the CD4 count. Remember, CD4 count only measure about 3% of your circulating CD4 T cell. The majority of CD4 T cell is in your lymph node and stuff. So the peripheral blood tells you very tiny stories of what's going on in the patient. And so I really think that when the patient achieve biological suppression, adherent on therapy, and they're doing well, you could probably consider stopping after 6 months. But it needs a clinical trial. You know, that's my impression. Second question about voriconazole. There has never been a randomized control trial comparing Vori with amphotericin B. That probably needs to be done. In China, my colleagues used lots and lots of voriconazole. And the reason is because they really don't like amphotericin B. It has so many side effects. They hate it and they don't like it. They use a tiny dose of ampho B. They actually use a teeny dose, homeopathic dose of ampho B for a long time. And so they really hate ampho B and they use voriconazole. But the experience from my multiple conversations with them is that they start the patient on ampho B for a day or two, and then they switch to voriconazole, and that helped. And I think that's a very good strategy. Ampho B has pretty long half-life. It's very fungicidal. It can kill fast, and you could stop after a few days, and then you could stop patient on Vori or even itraconazole if you want to make sure that the absorptions are okay. Unfortunately, therapeutic drug monitoring doesn't exist in many places in Asia. And so both voriconazole and itraconazole therapy are challenging. Hopefully in the future, we're going to have much more option. But to go at the duration, I believe that 6 months at the least, when the patient are biologically suppressed, it's probably be a safe time to consider stopping. When you have an antigen test, you could then follow, because an antigen actually resolve after about 4 months, very much like histo. So you could probably do that for galactomannan as well. And Thalomyces MP1 antigen, we find that it resolves. So perhaps there's a role for antigen to kind of help you gauge whether it's safe to stop. So there's some strategy that needs more research and evidence.
Right. Thank you very much. We will move to the next question, and this is for any of the members of the panel or for the speakers. Which imaging modalities are the most effective in detecting fungal involvement in the liver in patients such as this? Dr. Anup, may I invite you to comment, maybe?
For the liver, let me check the question. For the liver, I think for the liver, for the imaging modality, right? I think it's non-specific to diagnose the fungal infection, just performing only imaging. So I think there's a lot of things that can cause the liver pathology, even fungal or mycobacteria. I think we need like a tissue diagnosis. But for the invasive testing, liver is might not safe for our patient. That's why we could do for non-invasive testing lymph nodes, skin or chest or bronchoscopy. This is my answer.
Okay, thank you. Ban Hock, did you have your hand up?
No. Please carry on.
Sorry. All right. We will take two more questions. So the third question is, how would you treat tularomyces with itraconazole if a patient also had concomitant TB on rifampicin, where there's drug-drug interaction? So I'm throwing it open to any of the panel and speakers.
Dr. Methee, you must have seen many such cases.
Yeah, we have seen such case before. So this is the problem, because we cannot use the rifampicin with itraconazole together, because it's rifampicin is a strong CYP3A4 inducer that will eliminate the itraconazole. So what we do is we have to change the regimen for TB to something else, to take the rifampicin out and use something like levofloxacin to include in the regimen. This means that we need to extend the duration of TB treatment to more than 6 months. So we something like use isoniazid, levofloxacin, ethambutol, pyrazinamide, and then we can use itraconazole together.
Okay, thank you. I'm writing this down for my next patient that I see, and I'll refer to your regimen. Thank you. There is one more question. This is an interesting dilemma. What is the role of TDM, and is there guidance in terms of target level for itraconazole in consolidation? So, Yi-Chun, what do you think?
It is very difficult for me to answer this question, because in our hospital, for a long time, we less likely to use itraconazole, because we only have tablet and we did not perform the TDM for itraconazole. But it is very important for itraconazole oral. There's a two formulation, and you need to familiar with what formulation. And some is very unstable bioavailability due to absorption issue, and causing the treatment failure, despite of it is very the preferred azole for tyromycosis.
Okay. Any comments on that? Anyone?
Dr. Thuy,
Yes, I wanted to.
Yes.
Sorry.
No. Thuy, Dr. Thuy.
I want to hear Dr. question first.
Oh no, would you like to comment on that? What sort of trough levels in the consolidation phase?
Yeah, I wanted to add the pharmacokinetic of itraconazole is not straightforward, but because the MIC range is less than 0.25, you know, I personally would like to see a level above 1 microgram per mil for systemic fungal infection. So if you could, you know, get above 1, that would be great. And the dose, you shouldn't be more than 600, because more than that, we know there's you know, pulmonary hemorrhage issues, and there's some other issue with itraconazole. So it's very narrow therapeutic index. But above 1 microgram would make me feel a lot more comfortable. However, you know, in our clinical trial, the IVAP trial that I show you, we did PK study, we published on it. The average level that the patient achieved was dismal, was about, you know, 0.25. So the level from the itraconazole oral drug that we gave, even with observed therapy, you know, it was very poor. And so that probably could play a role in why they did poorly as well. But that's an issue with to address your question. The other thing I wanted to mention is oteseconazole is a brand new 4th generation azole drug that target a fungal cytochrome and not human cytochrome. That drug has been approved by the FDA 2 years ago for treatment of vulvar vaginitis, and it has a very, very long half-life. And it, as I mentioned in my slide, the MIC for Thalomyces and many, many more is very, very low, 0.004, and even lower because that's the limit that we test. And so my hope is that that drug can be used, can be tested for Thalomyces endemic, particularly with a lot of problem with TB co-infection that you mentioned. And so it doesn't get metabolized by human cytochrome, so there shouldn't be an interaction with rifampicin. That would be a fantastic drug for use. It's available in the US, it's available in China, not yet available widely outside of that. And there's a black box warning from the FDA that it shouldn't be used in women of childbearing potential. And because of animal study to show some oculotoxicity in fetal rats. But that is the same story with all the azole drugs, you know, so as long as you make sure you counsel patient not to, you know, to have birth control measure, then that should be fine. But that's a drug that I'm looking forward to testing in the future.
Okay, we're running out of time, but I'm going to be very naughty and to ask Thuy and anyone one question. I'm fascinated by your susceptibility testing methods. What advice would you give, you know, labs that may wish to set it up, particularly in terms of biosafety?
Yeah.
Methodology, do we do it on the yeast phase? What would be your advice?
Yeah, so we set this up, Sharon, using the yeast phase, and to make sure that it's safe and that to make sure that you can use it. So the way that we standardize the inoculum, actually not using the mold phase or the spore. It's much better to use the spore because it's single cell, you can count them, and much more reliable than the yeast, because in artificial medium, Thalomyces and histo and all of that don't look beautiful yeast like in vivo. They kind of like a sausage shape and it has some branches. So difficult, but what we're able to do is standardize the inoculum using just optical density, and it's very reliable. And so people can set this up in biosafety 2-level lab or conventional lab. And they can actually do conventional using the dye to visually look at the MIC rather than you know, using the CLSI. So there's definitely a utility for us to set up anywhere.
Okay, that you've given me a lot to think about, and well, anyway, so I may hand over to my co-chair, Professor Tan, to ask some final questions and to close the session. Thanks, Ban Hock.
Yeah, thank you very much. We are running out of time, so I don't think I'll ask any more questions, but I want to thank all the presenters. It's been an excellent session. The case was very well chosen. I must say thank you to the Siriraj team. And then, of course, thank you to the expert panelists for their very wise thoughts and comments. And of course, to the 2 topic reviewers, Professor Romani and Professor Thuy, for very enlightening lectures. So thank you very much. I must say a special shout out to Dr. Thuy once again. It's barely 7 o'clock now, and she must have been up before 5 in Duke. And thank you, of course, to all the attendees for coming and joining us this Wednesday evening. A survey will pop up on your screens when you leave, so please do help us by completing the survey. It will really help us when we plan future webinars. And finally, I want to promote the next conference that we're having. This is a face-to-face meeting in Bangkok this year. This is ISHAM Asia. This is the second one that we will be holding, or rather the first one in person. The very first one, unfortunately, had to be held online during the COVID pandemic. But do come to Bangkok. It's a beautiful city. And of course, we've got a great lineup of speakers and lectures waiting for you. So do sign up. Once more, thank you very much, everybody, and have a good evening.
Thank you.
Thank you. Have a
Thank
good
you very
evening.
much.
Thank you.
Bye-bye.
Well, that wasn't too bad. Thank you. Thank you to them.
Thanks, Ban Hock, for great sharing.
Yeah, no, thank you
Okay.
for your all your cooperation.
No. It's a great program, and thanks, Methee, for putting it together, and Yi Chun for coming, and Anup for coming, and our guest speakers. So I'll touch base later just to have the next session.